Jr. I'm the managing editor and publisher of the Journal of Emergency Management. Today's webinar is Stressors and Mental Health of Emergency Managers, Factors in Recruiting and Retaining Emergency Managers in an Era of Disasters and Pandemics. We're going to present the results from our first ever JEM Stressors and Emergency Management Survey. Quickly, an overview of the webinar. We'll do opening remarks. Our moderator, Sunny Patel, will chime in here. We'll present the survey results, and we will have several breakout panels. So, and then we will talk about next steps and future directions in terms of the survey, and then we will have a curated Q&A at the end of the session. Briefly, the abstract, this is a 90-minute, originally was a 60-minute webinar, but now it's a 90-minute webinar because we have so much content. We will address the current state of mental health and wellness in emergency managers and emergency management field. Emergency managers are obviously responsible for managing crises and disasters, and while their work is essential, it can be highly stressful and impact their mental health and effectiveness as emergency managers. This study aimed to examine the mental health of professional emergency managers and factors associated with their intent to leave the field before and during COVID-19 pandemic. As I said, we will publish the results from our survey, actually be a small section of our results. And our goal with the webinar is to address general and specific stressors and challenges in our profession. So I thank you for joining us today. And moving forward, quickly, our agenda, we'll do some housekeeping. We'll introduce our panelists and their bios. We'll talk about why this is important. We'll talk about the reason for doing the survey. We'll talk about results and so forth. Our discussion points, basically, what is the state of mental health among emergency management professionals? What contributing factors affect emergency managers' mental health and wellness? And what are contributing factors affecting the retention and recruitment of emergency managers? And, you know, what do these factors look like at the state, federal, and local levels? How does secondary traumatic stress impact an emergency manager's desire to leave the field? How does the emergency reaction questionnaire rating and the number of disasters responded to, the number of years in the field, age, education, and experiential knowledge impact an emergency manager's desire to leave the field? We'll discuss other static variables and their effects on the emergency manager's mental health. And of course, we'll share the findings in our survey. So this is presented by the Journal of Emergency Management. I want to thank all of our presenters for joining us today, and I want to thank our team. You guys have just been great. It's really been a pleasure working with you to pull this together. Funding for this webinar, for the production of the webinar, is provided by the National Institutes of Environmental Health Sciences under award number U45 ES 019350. And that was in cooperation with Nova Southeastern University and the great folks down there, Dr. Grant and Dr. Cohen. Thank you very much for your support. This is a medical disclaimer. Basically, the opinions of the panelists and the moderator are their own and are not to be considered medical advice. If you feel you're in crisis, please contact your healthcare provider or one of the resources below. Please take our post-webinar survey. It will be located at this link here, or you can scan this 2D barcode, this QR barcode with your phone. We will have this at the end of our presentation. Some basic rules. Basically, the opinions of the panelists and the moderator are their own. By attending the webinar, you confirm your acceptance to being recorded and voice your image if we open it up. Please present all questions via the Q&A function of Zoom. We will try to address all questions in addition to previously submitted questions. If the webinar opens to verbal and on-screen comments, please remain muted until we call on you to present your question. Please ask concise questions, cite your sources, and limit opinion and criticism. Please do follow up with our speakers with additional questions and solutions. This is an ongoing discussion. This is an important topic in the field, and we have some great panelists, and the goal here is to improve the mental health and hygiene of emergency managers. Please send any future topics, comments, and suggestions to the JEM mailbox. So, thank you for participating, and I'm going to turn it over to our moderator, Sunny Patel. Sunny is an award-winning researcher and a former National Institutes of Health Fogarty Global Health Scholar. He is a presidential fellow at the Transcultural Conflict and Violence Initiative at Georgia State University and visiting scientist at the Harvard Humanitarian Initiative and also at the Harvard T. Chan School of Public Health. He is also a non-resident fellow at the Joint Special Operations University. And today we're going to go with the abbreviated introductions here because I know everybody wants to get to the data. So Connie, please take it away.
Sure, no problem. Hi, everyone. Good to be here. And we got a lot of topics to cover. And so let me just quickly introduce our esteemed panelists. First, we have Dr. Chris Stout, is a renowned clinical psychologist and the founding director of the Center of Global Initiatives. He brings a wealth of experience from academia, nonprofit work, and his role as Chief Clinical Officer of Prevail Health. Dr. Stout's diverse background positions him to offer invaluable insights into the mental health aspects of emergency management. And just know that all our panelists have received our paper ahead of time and our slides, so we'll be able to have a really fruitful conversation. Next, we have Dr. Andre Andy Bernard, who serves as FEMA's Chief Medical Officer with a background in emergency medicine and an extensive experience in the United States Army. He is uniquely qualified to discuss the health aspects of emergency management, a true expert in the field, and a pleasure to get to know during our conversations with him. Next, we have Kim Guerrero, is the founder of the CEO and Mosaic Solution. She joins us with over 25 years of experience in crisis emergency management, including international work. Her innovative approach through Crises Athlete combines neuroscience and various disciplines to foster resilience and peak performance, making her a valuable contributor to our discussion and a wonderful assets in this study. Next, we have Dr. T. Lucas Haller, is an associate professor at Nova Southeastern University and is an expert in health policy, statistics, evaluation, and research methods. His work addresses a range of public health issues, and his expertise in statistics and political determinants of health provide a unique perspective in our study. And of course, our wonderful Dr. Timothy Erickson is a Harvard Humanitarian Initiative core faculty member, brings an extensive knowledge in humanitarian health and mental health in global conflict settings. As an emergency medicine physician and a division chief of medical toxicology, his insights into global health, into mental health crises are invaluable to our discussion. With that, I welcome everybody and kick it back to Richard to present the findings, and we'll get to the first panel soon enough.
Thank you, Sonny. Be here. Thank you, Sonny. Appreciate that. All right. Let's see here. Well, let's get started on here. This is the important part of this whole presentation. Well, why do we need a mental health survey of emergency managers? What are the survey goals and designs? Well, briefly, JEM was started back in 2003 at the request of the FEMA higher education team, and we started the journal back in 2003, and over the past 20 years or so, we've gotten to meet some tremendous folks in this field. We find that emergency managers are a unique type, but we found, when we did a special higher ed issue several years ago, that it really looked like we had people who were leaving the field on an accelerated basis. And at the time, we couldn't put our fingers on it and find out what was going on. And then as we proceeded through the field, but into the pandemic, we started to hear a lot of concerns from the field of people leaving the field wholesale. So what we find is that, the emergency managers suffer from high stress, burnout, and you have a lot of trauma experienced by those emergency managers. We did know that suicide was the leading cause of death from first responders. We knew that there's no specific mental health data on emergency managers. And however, many of those come from frontline organizations. And we have large numbers of emergency managers leaving the field predating the pandemic. And it's really important because as these emergency managers leave, it's tremendous brain drain. So we have poor knowledge depletion when they do leave the field. And we know that college programs struggle to produce seasoned emergency managers. So our key questions that we came up with were basically, are there underlying mental health issues impacting emergency managers and their retention in the field? What other factors contribute to emergency managers leaving the field? And how can we address these challenges to retain and support emergency managers? They are a critical workforce. So how is the survey constructed? Briefly, we created a comprehensive 153 question survey in Kobo toolbox. We included breakout panels for specific questions where needed. And we wanted to focus on several aspects. First, we wanted to do a mental health assessment. So we utilized the secondary traumatic stress scale question set to accurately assess the respondent's secondary traumatic stress score. We wanted to take a look at their personality. We wanted to profile their personality. So we incorporated what was called the emergency reaction questionnaire to confirm and determine the respondent's personality type. We wanted to distinguish between those who run to danger from those who run away from it. And we wanted to take a look at workplace culture. And so we included 8 questions to assess the organizational culture at the respondent's workplace. So additional questions that were included in the survey included professional stressors, personal stressors, mental health resources available to the respondent, risky behaviors of the respondent, job satisfaction, sufficient education. Did they feel that they had sufficient education for their job? Their professional role and their experience. We wanted to gauge their level of guilt, sadness, anguish, and anger. We wanted to see if they were bringing stressor homes and to find out if the home was an effective de-stressor. We wanted to look at technology and people. We wanted to look at organizational structure and team building. We wanted to look at emergency manager traits. We wanted to look at primary and secondary professional length. And we wanted to look at their educational background. We wanted to look at their practice demographics, their personal demographics, and then we wanted to look at when their submissions, the survey were submitted, because we wanted to see if seasonal affective disorder was an active contributor to stressors in mental health. So, yes, we are seeking additional funding to further explore this really comprehensive data set. And so these are all the question sections in this particular survey. It is quite extensive, and at this point we have 165,000 data points in-house in this database. So let's talk about the secondary traumatic stress scale. It was developed in 1988 by Dr. Brian Breed. The secondary traumatic stress scale is well validated and has been utilized recently to assess the mental health of the nursing staff during the very intense early COVID pandemic in Italy. Bigley defines secondary traumatic stress as comprising the natural consequent behaviors and emotions resulting from knowledge about a traumatizing event experienced. It is the stress resulting from helping or wanting to help a traumatized or suffering person. To further this definition, secondary traumatic stress can be defined as the development of symptoms characterized as post-traumatic stress disorder following indirect exposure to trauma. And so the STSS has an abbreviated version, and in previous validations showed that the shorter version to be accurate in assessing the target's mental health. So the 17-question secondary traumatic stress scale was added to the survey immediately after the informed consent and mental health notification. So what were the results? What we found was that 52.9% of emergency managers experienced mild to severe secondary traumatic stress. Chronic or traumatic stress can have severe impacts on an individual's long-term physical and mental health. Moreover, the contributions of untreated or undertreated stress may link to poor organizational culture and result in increased workplace stress. It also impacts the quality of life. It increases tension at work and at home. And it may lead to aberrant and risky behaviors as coping mechanisms. Other results. We found that 29.3% experienced moderate to severe secondary traumatic stress. This was a shocking finding. Moderate to severe secondary traumatic stress directly affects decision-making and leadership skills. These are core to emergency managers. It impacts the quality of life, directly increases tension at work and at home, and it strongly suggests an increase in risky behaviors. The trend is alarming, as our findings confirm that untreated or undertreated secondary traumatic stress can increase the likelihood of leaving the field by almost 3 times. So clearly, there is significant undertreated and untreated mental health issues in emergency management. So basically from our paper, this is the chart that's in our paper, and what you'll see is this is in yellow, higher secondary traumatic stress. And you'll see here that people with higher secondary traumatic stress are 2.79 times more likely to leave the field. Pretty startling. So moving on, we then wanted to look at personality types in emergency managers. We wanted to confirm their personality type. We utilized the emergency reaction questionnaire. This was developed in 2020 by Dr. Anzito. We know that personality types plays an important role in how humans manage and react to stressful situations. Our team determined that it was critical to assess the individual personality types, basically fight versus flight instincts, and their impacts on the overall health of mental health of emergency managers. This questionnaire was originally created to look at personality types of individuals during an airline crash and disaster response. We utilized a modified 13-question emergency reaction questionnaire, and we added it to the survey right after the secondary traumatic stress question. So what were the results? This is the chart from our paper we presented, and what you'll find in yellow is this is the emergency reaction questionnaire index. And so briefly, what we found was that emergency reaction index scores did not directly impact the person's secondary traumatic stress score. We found that the ERQ index did not correlate highly with their desire to leave the field. And we effectively confirmed that emergency managers are run to the disaster types. So moving forward, we find that many emergency managers experience significant stress. 32% report that they receive insufficient critical stress debriefing. How can that be improved, and what additional services are needed to improve emergency managers' mental health? So we're going to go into a little panel discussion here, and we're going to bring up our panelists, and we're going to discuss. Let's bring our panelists up. Go ahead, Sonny. I'm going to let you lead this, please.
No worries. Thanks, Richard. Thanks, everyone. I know we're going to get a lot of stats and a lot of data here, but we need to set the stage. So thank you, Richard, for setting the tone and setting the stage. We're going to bring in Dr. Stout, Dr. Bernard, and Dr. Erickson. I believe Dr. Erickson's in the backstage right now. But we'll start with first with Dr. Stout. Chris, we sent the paper ahead of time. You've seen some of these results in here. I know in the past webinar that you had with us, this wasn't surprising for you. It was very concerning. But maybe you can give a little bit more context for those that are maybe not familiar with some of these scales and what it means in the workforce in terms of the secondary traumatic stress and what it means a little bit in the impact for emergency managers. And you're on mute, Chris.
Thank you for that, Sonny. Thanks, Sonny.
No problem.
Good to be on, and just kudos for such a important work, and the amount of variables and things that you guys have taken a look at is quite impressive, and the write-up in the paper also is likewise. In terms of your question, I think that one of might sound funny to say, but one of the positive things that I think we got from COVID was some level of destigmatization of an appreciation of stress and mental illness for folks. I think it nevertheless, as your data show, that that hasn't kind of taken care of everything. People, I think, still have some level of trepidation or stigma to reaching out and asking for additional help. I thought one of the highlights that Richard just pointed out, the aspect of not perhaps having enough debriefing, but also maybe the qualitative aspect of, well, what is that debriefing like? Is it just a pro forma kind of thing to go over the data and the experience, or are there other additional opportune times that maybe in a more private kind of setting that individuals that may be experiencing some secondary trauma to whatever that event was can have an opportunity to either talk with someone that's a colleague, maybe a mentor, maybe a supervisor, or be able to get referral out for someone that has expertise in working with populations like this. Just a quick little point, one of the things mentioned in my bio with Prevail Health, we started off working with active duty military and veterans, and they very much have an appreciation of being able to work with a colleague and a peer to talk about their stress. And I think there's a greater level perhaps of empathy and a greater level of trust with that. So those might be some of the things, not to jump ahead of what we might do in the future, but I would have a little bit of a sneaking suspicion that those may be some things that are absent across the board that are responsible for that statistic that Richard shared.
Thank you, Chris. And we have Andy here who, you all doing like the best you can at FEMA and doing some good studies early on, like recently. I love to you to take this opportunity to share. I think it's recently been published, along with some of the services that you all been doing during the pandemic that maybe a lot of people don't know that FEMA's been doing. Andy, go for it. The stage is yours.
Good. Thank you very much. So we haven't actually published any data yet. We're finishing up our data analysis. We've got some preliminary results. It's interesting that you just did this study because in the relatively recent past, Congress inquired from FEMA as to the feasibility of doing studies on the emergency management community, because there was a concern, obviously, at the leadership level, with the increasing disaster cycle, more intense disasters, all superimposed on the pandemic, what the actual mental health state of emergency management was. And so I'm very gratified that you've done this work to kind of help shed some light onto that. Intuitively, as I came on board during the pandemic and we kind of did a comprehensive look at the overall health and well-being of our workforce and how we could sustain them, because we were seeing significant attrition. We kind of intuitively knew that there were likely mental health challenges that were simply unrecognized with any objective data, other than people just leaving, or, the scuttlebutt, at the water fountain about how they felt like they were unsupported. And so what we tried to do initially was to inject and build a mental health support system that we did through sort of a tiered structure, where we focused at the lowest level. We focused in on the employees, held various mental health workshops on recognizing the stressors, looking for red flags, and reinforcing the message that this is not an uncommon thing. It doesn't mean that you're weak or anything like that, but that it's a natural response to the things that we have to do in emergency management. We then next had a tier level where we started creating a peer support system within FEMA, and under psychology assistance, basically started training folks in the workforce to help provide some psychological first aid to their coworkers when it was necessary, but also to be like a sounding board where they could, trip an alert and say, hey, you know what, I'm kind of looking at the atmospherics here and something doesn't seem right, and kind of focus in attention. Our next level was, originally we brought in 2 psychologists. And then as we saw, while they were doing sort of one-on-one private workshops, providing some assistance, helping people deal with stressful events like employee deaths and grief counseling, we came to realize that there was far more work than 2 psychologists could accomplish. And so we've recently added 11 counselors, 10 of which are aligned with the FEMA region, and the 11th counselor is native to Puerto Rico to provide culturally sensitive support to the folks in Puerto Rico, since they, are not only emergency managers, but almost on an annual basis also become disaster survivors. And then, on our final level, it's supported by, referrals to both EAP and long-term mental health assistance, through folks' federal health insurance. And it's been very positively picked up by the workforce. And so, we're looking to continue to expand that. One of our goals is to very rapidly bring mental health support into the early response phase during a disaster, particularly for those disasters that are going to have, tremendous high stressors, high fatality event like the Maui wildfires this past summer, where we had mental health support on the ground very quickly. And that's sort of the model that we're going to continue trying to pursue. As far as some of the data that we have seen, we did do a survey of emergency managers within FEMA to kind of get an idea of the prevalence of stress. It's definitely out there, and we're seeing some results that are mirroring what this study is showing, and particularly with the apparently greater vulnerability of the younger folks, the people who have gone to fewer disasters in the beginning and they haven't kind of grown more resilient to being able to manage that situation over the length of their career. So definitely a lot that needs to be done out there. So, and I'll turn it back over to you. Thank you.
No worries. Thank you for sharing that. I mean, it's really great to hear of and updated of all the things you're doing. I want to bring in some of our co-authors on the study, Dr. Tim Erickson and Kim Guerrero on this. I know when seeing the data and writing up the data, we were talking about effectiveness in terms of reducing it. And, as you heard, both Chris and Andy talks about various different aspects of services that, can help and whatnot. Maybe go to Tim, I think you're on here, Tim Erickson, maybe go with you of kind of talking about some of the effectiveness of kind of reducing the stress of and also kind of some of the survey data of what it means to you.
Sure. Thanks, Sonny and Richard, for the invitation to be on this really important study and panel. And Sonny, can you see me okay and hear me okay?
Yep, we could hear you, and I believe we could see you. So go for it.
Okay, wonderful. Yeah, thanks for the opportunity. And first, I'd echo a lot what Andre and Chris have said. We're all in this together. Emergency managers serve such an important part of our response, whether it's a pandemic or a natural disaster. And certainly we've seen this on the front lines in emergency medicine. I just came from a meeting where our nurses on the front lines are really feeling the effect of not just the pandemic, but overcrowding and the challenges of our healthcare system. So I'd first say, you're not alone. We feel this. We feel this on the front line. COVID certainly was a challenging time where we thought we would rise to the occasion, get through this together. And then there was another variant and another wave and another portion of the pandemic. And those responding with the greatest humanitarian initiatives started to feel the beatdown of the pandemic and the stress of frontline work and the stress of responding to disasters and working extra hours and overtime because it's what we do. It's what we're trained to do. But with that, there's an impact, and the impact can be negative and long lasting on mental health. And I think Dr. Stout said it really well. It's that whole idea that it's okay to reach out to say, I'm not doing well, I need help, is very hard for us to do because we want to feel like we're the ones responding, we're the ones there to help, and we shouldn't feel vulnerable, but we are, and we're very vulnerable, and we need one another and the resources to actually help and know when to say, I need a break. I think this paper is important because it points out really a lot of what we already knew, but it gave us objective data, truthful data, I believe. And now we know we have an issue. How do we respond to it? So I appreciate the opportunity. Again, as I said at the outset, high respect for emergency managers. We need you. We need a young workforce. We need an experienced workforce. And we're seeing it at all sectors of healthcare, whether it's nursing, paramedics, those in nursing and rehab centers. Certainly the physicians are feeling it as well. So you're not alone, and we have to circle the wagons and bring in experts in behavioral health who know how to best treat professionals who are feeling the burden of all this. So thanks again.
Hey, thanks, Tim. And we'll kick it to Kim to end our first panel. Kim, maybe you could bring in the perspective with your experience of rolling out the crisis athlete with neuroscience and other disciplines. Go ahead, Kim.
Awesome. And I know we're running short on time, so I'll make this quick. But one of those things that I think we're seeing is also we're seeing an increase anecdotally in the number of suicides by peer counselors. And so there's additional elements that we really need to look at to either train that workforce better or support them. One thing that needs a little bit more research is, are they coming in with such higher degrees of either PTSD or secondary traumatic stress that is leading to that? But as there's not enough mental health professionals in this country to meet the current demand, you add in the need to also have additional training to understand how to address this audience. Because some of those traditional elements that you might hear, right? Well, don't catastrophize, don't think worst case scenario. And this workforce has to go run to that. They have to think about it, even if they're not in the field. And so we really need to look at that as we look at what the impact is and why emergency managers aren't getting the care they need in the landscape of the fact that the mental health profession can't keep up with where we are in terms of demand. Sunny, back to you.
Yeah, thank you, and thank you for the panel for the. We're just getting started, everyone. So buckle in. We got a couple more rounds of round robin. I'm going to bring back to Richard to bring up the next kind of key aspects that we found in our findings, and we'll be back shortly with the second round of the panel. Go ahead, Richard.
Great, thank you, Sunny. Let's see here. Good. Okay. So thank you to the panelists. That was outstanding. As we mentioned, from a SPAC standpoint, 2.7 times emergency managers with higher secondary traumatic stress were 2.7 times more likely to leave the field. 53% had mild to severe secondary traumatic stress. 29.3% had moderate to severe secondary traumatic stress. The ERQ does confirm that they are run to the disaster types, and 32% report that they receive insufficient critical stress debriefing. So we then decided that we wanted to look at, we postulated that organizational culture was a really important aspect of how emergency managers manage stress. And so we had folks on our team who said, we really want to look at organizational culture as it affects mental health. And so I'm ahead of myself on the slide. So it was postulated that the organizational culture might be a major contributing factor to an emergency manager's mental health. The JEM survey team, the members who are specialized in organizational development, developed a short novel series of 7 questions to assess and quantify the impacts of organizational culture on the subject mental health. It was postulated that organizational culture may be a major contributing factor affecting the retention of emergency managers. So what were the results? This is the data from our survey and our paper. And what we find is that, looking down here in the yellow, better organizational culture, we basically normalized at a 1.0. We find that poorer organizational culture, emergency managers who work in an environment with a poorer organizational culture are 2.8 times more likely to leave the field. That was a startling find for us. 83% of emergency managers who considered leaving their jobs or the field altogether cited poor organizational culture as a primary cause. So obviously, organizational culture is critical to managing the workforce and managing their mental health. So other survey results that may play a role in organizational culture include 36% report that they have a lack of praise from their supervisor. 20% feel unsupported in their decision making. 51% says their job is too political. And 62%, or if I flip it upside down, 38% feel that they are not making a difference in their field or in their organization. 61% are not using mental health services that are provided. This was a startling number. Other numbers and other results which may play a role, 53% felt guilt, sadness, anguish, or anger if they can't save everyone during a disaster. This was a startling finding that we didn't expect. And then when we went and looked at that level of guilt, sadness, anguish, or anger, we found that 53% felt guilt, sadness, or anger. Of those, 72% feel moderate to intense guilt. So these emergency managers are internalizing the fact that they can't save everybody. Okay, very interesting finding. So we're going to go back to another round of panel discussions here. How can we address, how can this all be addressed at the organizational level? Are there small steps to improve the organizational culture that improve the retention of emergency managers in that organization and in the field? And then how do you start a major overhaul of an organization's culture? I'll turn it back to Sunny to lead our panel.
Thanks, Richard. Kim, we'll start with you. I know from the last panel, you mentioned a little bit that kind of ties into cultural. How about you take a little bit more minutes to share a little more of kind of things that you've seen that could improve cultural and mental health at the organizational level?
Sure. So there was a lot that we looked at in this field, and we really wanted to study the culture piece of it. We know it's kind of a buzzword out there, but as we were looking at it, we kept hearing real stories about kind of toxic work environments that were there within this field in particular. And so we really asked around that leadership question, and really it came down to, and the results are not really super surprising. You see the same trends that are happening on a national or global level. People that have great supervisors, and by great, I mean empathic, compassionate, listening, understand the real juggles that people are doing, not just in the workplace, right? A lot of the burnout models that we see are really focused on work, but people's burnout extends because they're trying to juggle both home and work, regardless of where they're at. The time pressure that's there, the time to respond to everything. That's why that statistic that was there that Richard gave of people really feeling that deep level of guilt for not being able to save everybody, and sometimes not even save their own families, as they're being called to the disaster just as they are also being called to help their family. And so we wanted to look at that, but leadership makes a difference. If we can train our leaders and equip them better, then it makes a difference. People will stay for less pay and a bit more stress and pressure when they are supported by good leaders. And there's a lot that goes into what is a good leader. So we don't have time to go on that into a call. But we also know that toxic leaders, those people that put people down, that don't handle the stress well, that blame and put people down. And really, that also factors into the secondary traumatic stress and post-traumatic stress. Those reduce your ability to be compassionate, to be empathic, to lead well, because you're tired, you're exhausted, and your brain can't function, and you're not able to make good decisions, even though you may think that you are. And so that has a huge impact on this. And so how do we kind of address, is it the stress? Is it a lack of training? Probably all of the above. There's also I want to think about on a culture piece on a national level. Disasters are increasing in frequency, scope, and scale, but we're still using older models in terms of how we do that. So people are still measured in terms of how fast they respond. We recently heard a story about an emergency manager who took a leave of absence to take her daughter to graduate school, or to college, and then on a trip. She took 2 weeks off, the first time in 6 years, and a disaster happened in their jurisdiction, even though they had strong deputies in place, and she was fired because she was gone and didn't come back on the trip, and they couldn't reach her immediately. So how do we shift? And that story is not alone. It seems to be more prevalent in this field than we hear in other industries. So how do we shift this culture? How do we shift it on a national level? How do we reset public expectations of what emergency managers do? If emergency managers are the ones that are called to convene all the stakeholders together versus that very specific domain of, say, fire, police, EMS, and public works, and all the aspects that come in for all disasters, for all emergencies, how do we equip them so that we can retain them better, and also they have the support that they need? And that comes down to culture at the team level, the organizational level, and even at the national and international levels.
Thanks, Kim. Yeah, thanks, Kim. And let's bring in Andy. Andy, from the first panel, you talk about changing the culture a little bit, of adding psychologists and services. Maybe you can expand a little bit more of kind of what have you seen so far of some of the changes that you're making that's addressing some of this cultural and making it a little more inclusive for mental services to occur.
No, absolutely. And thanks for that question. One of the things I'd like to echo with Kim is, that the actions and behaviors of supervisors are super important. And so as part of, like when I mentioned, putting tools into people's tool chests, as the lowest tier of our support, We've also developed education that our mental health professionals do for supervisors specifically, helping them to adopt better behaviors, looking for those red flags, and and getting some feedback as to what's going on in their sections so that they can adjust their behavior before it gets to that toxic level. And really giving them the tool to better support their employees, and also giving the employees an instrument of where they can sort of vent about their supervisors before it kind of builds up to a situation. Other things in the culture, it's always been, there's been a great reluctance because if FEMA asks you to deploy, then the expectation is that you're going to deploy. And one of the things we implemented this year, just before hurricane season, is we distributed a self-assessment. You didn't have to submit it to us. It was purely there for you to kind of review things, but it helped identify potential conditions that you might not be thinking about, and while there were, while it looked at a number of physical things, it also looked at mental health things. Are there ongoing stressors in your life? Have you recently been started on some medication, for a mental health issue that where the medication may not have stabilized? Do you have enough of the medication on you that it's not going to become a problem? Because we've seen some people who decide when they deploy to stop a psychoactive medication because they don't want to be on a medication when they're deployed, and then suddenly things go to pieces 2 or 3 weeks later when after the medication's washed out. So we're giving them an opportunity to basically help self-identify some of those things. We encourage them to talk to their own personal healthcare providers, and and then make an informed decision about being able to turn down a disaster where, based on the, if you're saying I can't do this, and you don't have to give the specifics, but you're just basically saying it's for a medical reason, that doesn't get held against you. It's just like the disaster was never offered to you, and so people feel a little bit more comfortable in making sure that they can make a decision on when the right time to deploy is. Now, that's not going to work for everybody. It does work on the federal level because we obviously have access to a much larger community of emergency managers than a small municipal department would have. But altogether, it's basically trying to represent that to the workforce that we're there to support them. We're there, that we understand that not everybody can go all the time, and to basically put those communications tools into place to to make the place more supportive and make it into a better community environment, if you will.
Thank you for sharing that. And let me bring in one of my favorite clinical psychologists, Chris, into the conversation as well. I mean, you heard Kim, you heard Andy, and also, I know we had some conversations about, the organizational culture and how that plays into the mental health, especially with improving retention. And maybe you can provide some of, I know you've done some of this work in other organizations. Maybe we start with kind of things that you've seen and done.
Sure. Thanks, Sunny. Just to maybe highlight and underline, I really appreciate what Andy was saying, because I think that whole aspect of self-assessment is a very nice initial non-threatening way to get people into the habit of feeling comfortable of sharing that kind of information. I think one of the things that Kim had said just sort of reminded me, and just to kind of say it out loud here, there's no reason that emergency managers would be insulated against what we've seen in the media, for the last year, of what's called the Great Resignation. It's happening across all fields, so there's no reason that it wouldn't necessarily, happen with us. And in that sense, it seems like it almost, would be an expectation. And you also hear about quiet quitting. Well, you can't, as an emergency manager, quiet quit. You can't just, sit at home and do your Zoom calls. But I think in terms of organizational culture and organizational kinds of assessment, I think getting in, if there's opportunities, depending upon a situation of having human resources be involved, they can be sometimes a good advocate third party. They can have usually good skill sets in terms of employee evaluations, supervisor evaluations, what we call 360 evaluations, where a number of subordinates would give anonymous information and opinions about their supervisor, and it's typically done, if it's a non-toxic environment, it's done in a very supportive, collegial kind of way. And I think, taking a look at those, seeing where they work in other kinds of areas, developing a set of best practices that might be generalizable or scalable to other areas, I think is important. On the other hand, I also appreciated what was said, that there's cultural sensitivity to our colleagues in Puerto Rico, not just because of the devastation that they seem to repeatedly get, but also because of other kinds of cultural norms, and bring those kinds of things into play. Because I know disasters in Mississippi might be dealt with differently than disasters in New York by virtue of those that are impacted by it, and how we go in to deal with those kinds of things. And I think looking at all those things perhaps together in concert might help develop not only better empathy to those that we work with that have been victimized by a disaster, but also by virtue of how we work with each other and our colleagues.
Yeah, thank you for that. And I know we have Tim Erickson here as well. Tim, I'm going to have you start the third round robin, just because I'm looking at time. So I'm going to have you start, and hopefully it'll connect with the organizational culture on the next results bit. So Richard, I'm going to kick it back to you to present the next bit, and hopefully we get Tim Erickson and others to chime in.
Okay, very good. Thank you, Sonny. Thank you, panelists. That's outstanding. So briefly, a recap slide. Where are we? Well, basically, I believe we have a field that's in crisis. From a secondary traumatic stress point, we know that 53% of emergency managers report mild to severe secondary traumatic stress. 29.3% report moderate to severe secondary traumatic stress. Those with higher secondary traumatic stress are 2.7 times more likely to consider leaving the field. From an organizational culture standpoint, we find that emergency managers in poor organizational culture are 2.8 times more likely to leave the field. 83% of those considering leaving the field cited poor organizational culture as the primary cause. And when we look at emotional impact, we find that 53% of emergency managers experience guilt, sadness, anguish, or anger. Of those, 72% feel moderate to intense guilt. So, the challenges are, how do we retain emergency management workforce under this level of stress? And where are these emergency managers turning to if they leave the field? Before we go and answer those questions, I want to quickly bring up the results of the polls, because I think that this is really critical. And I'm sharing these with you. Question 1 was, do you know of an emergency management colleague who might need mental health support? 50% of you know an emergency management colleague who could use some mental health support. Do you feel comfortable suggesting mental health services? Well, this is a good number, because 81% of you feel comfortable going up and suggesting that they get some support. Do you believe that there is stigma attached with seeking mental health services for stress? And this is really an important topic. And I think Dr. Bernard may address this a little bit later. He certainly just addressed it when we were discussing it before the webinar. 85% feel there is stigma attached to people who are seeking mental health. And we really need to address this. We need to remove the stigma. It needs to be a normal course of managing your mental health and hygiene. Next question is, would you trust a colleague who is receiving services for stress or mental health services? And so when I made this question, we had no and yes, and I wanted to get a little bit more detail. So only 4% it said, would you trust a colleague? Only 4% would not trust that colleague. 51% said they would trust that colleague, and 45% would trust their colleague more if they're getting mental health services. That's a really great answer. And so having recently taken some mental health first aid, I wanted this question: do you check in or ask your colleagues how they are doing on a regular basis? 18% do not, 82% do. This is really great. I think this is a shift in the field. And do you really listen to the response? This question was, I put in there, was based on the training I'd taken recently. Do you listen to the response? Do you try to solve it? So 19% listen only, 41% listen and try to resolve. And this is an interesting discussion for mental health experts in the field. 40% listen and try to suggest professional help. So very interesting responses from the field. So thank you very much for taking that poll. So moving forward, and I apologize if we're moving quickly. We have a lot of stuff to cover, so I apologize for that. So let's take a look at the emergency management workforce trajectory. It is a field in crisis, we feel. So pre-pandemic, we found that 43% of emergency managers considered changing jobs. Thanks to the pandemic, 64% of emergency managers considered changing jobs. And of those, 46% contemplated changing fields altogether. 46% contemplated leaving emergency management totally. So of the 634 people who ever considered changing their jobs, 46% were looking to go outside the field. 69% explored different jobs within emergency management. 18% contemplated retiring from emergency management altogether. 26% thought, maybe I need to leave for more education. 10% wanted to leave the field for other reasons. And so the significant takeaway from this really is that of the 634 people out of 903 respondents who considered changing jobs at some point, a staggering 46% expressed the desire to leave emergency management entirely. This situation is unsustainable for the field. So take a look at who's leaving and where, and I know Dr. Bernard talked a little bit about this. Basically, we looked at the age of the respondents, and we found that age is a strong predictor of changing jobs. We found that 18 to 35-year-olds are 2.7 times more likely to change jobs. And our question going forward is there something unique to this age group? We then looked at the number of disasters managed, okay? And here we found that the hot spot was people who have managed between 3 and 5 disasters were 1.9 times more likely to change jobs. So we know that the number of disasters is a predictor of changing jobs in the field. And so are there stress-related issues that are driving away emergency managers from the field? So we then also looked at years in their primary position. This is a chart from our paper, and when we took a look at here, we found some very interesting numbers here. And when we looked at the data, we found that people who had been in the field from 0 to 1 year were 2.796 times more likely to leave the field. This is startling. These are people who have come into the field either through higher education or through matriculating from one of the service response professions, and they're getting into the field and they're leaving after 1 year. And so the question that comes up out of this is, do we need more experiential learning? Do we need co-ops? Do we need internships or something similar to that? So moving forward, we took a look at their highest level of education. This was really a startling finding. We found that emergency managers with their master's or doctorate level degrees were 3.48 times more likely to leave their field. They're basically looking at the level of pay, responsibility, stress, what have you, and they were taking their sheepskin and they were leaving the field. And these are the thought leaders of the field. These are the people who are the repository of the knowledge in the field who are actually just leaving the field wholesale. So we wanted to take a look at where they're going. And this is a chart from our paper. And so 46% considered leaving the field, 69% considered changing jobs in the field, 26% considered going back to school for more education, 18% considered retirement, 10% considered leaving for other reasons. And these numbers are just not sustainable in a highly skilled workforce. So we're going to come back to another panel discussion about who is leaving and where are they going. So again, just in terms of reading this back up, 18 to 35-year-olds are 2.7 times more likely to leave the field. Those with 3 to 5 disasters are 1.9 times more likely to change the field. EMs with 0 to 1 year of experience, they really want to leave the field. seasoned emergency managers with graduate degrees are very likely to leave their field. And so where are they going? As I said, so I'm going to throw this to the panel, and Sunny, take it away, please, sir.
No problem. Thank you. I'm going to start with Tim Erickson because I know we missed him on the last panel with the timing wise. But Tim, let's bring you into the conversation, and you can connect it to the previous one and to this one because they, knowing you in our conversation, cultural matters, and maybe some of that is why they're leaving and how they're leaving. But over to you.
Yeah, thanks, Sonny, and thanks for the statistics, Richard. I'm familiar with them, but to hear them again, it's a concern, and we have to acknowledge it and also change the culture. And the culture needs to be changed that it's okay. You're not invincible. You're not indestructible. It's okay to take a break, take time off, take care of your well-being, circle the wagons and your family, and make that part of the culture, not even call it mental health. It's just part of the organizational schema where there's resilience training, sustainability. You want to avoid burnout. You don't want people leaving the field of emergency management in 1 year. You need an influx of youth as well as sustaining those who have experience, several disaster experience that can train the younger new wave of emergency managers. So it's so important to acknowledge this is an issue. Maybe we need to call it something else and make it just part of the everyday schedule, vernacular, and that people who take time off are not looked down upon. It's not a sign of weakness. It's just a part of making sure the organization has long-term availability to respond to those that are most vulnerable. And right now, we're finding that emergency managers are part of those who are vulnerable. And we have to circle the wagons, call it like it is. And I think it's a wake-up call. These statistics are concerning. And if we just report them and do nothing about it, we're not doing our fair share for the future of this field. So thanks.
Thanks, Tim, and thanks for the big takeaway there. And I'll bring in Andy because Andy, I know you talked about it earlier with stigma and other things. Maybe it's a good time to kind of, I know you're still going to be publishing the internal study, but you saw some of the preliminary data there. You mentioned it earlier. Maybe you could elaborate a little bit further here.
Yeah, thank you. So as far as the stigma is concerned, the challenge is that people, so many people experience mental health effects, from their work in some way, shape, or form, whether it's just stress, whether they're having actual genuine trauma from what they experience at a disaster. And, and a lot of times they feel like they're the only person, because everybody else is not talking about it. And so they feel like they must be weaker or, more vulnerable. And one of the things that I've encouraged our folks to do is to have our senior leaders basically speak up and to their credit, they've stepped forward. And, when you have an associate administrator, or as an example, step up and say, I had a mental health issue and I went and got help and it got better. It shows employees at lower ranks that this can happen to everybody, and that seeking help is not something to be looked down upon, but it's something to be encouraged, because we try very hard to portray asking for help as a sign of strength. A number of our people obviously require security clearances for some of the work they do. And so our mental health professionals have been working very closely with our chief security officer to basically put out information for employees to assure them that, again, simply by seeking help, it actually speaks favorably and makes it less likely that their security clearance is going to be negatively affected than if they let something fester and turn into a big problem down the road, that where wouldn't be willing to seek help. And it really requires a major mind shift, is that, everybody, if you sprain your ankle, everybody sprains their ankle at some point in life. But, we don't take that same sort of consideration for mental health issues. And factually, we all deal with something that we have difficulty with overcoming and accepting. And, we really have to sort of change that mindset. And I think a lot of it probably needs to be starting in the colleges where we're teaching our young emergency managers, and that needs to be part of the educational process right from the beginning, is to change their minds and prep them for the fact that if you're going to go into an emergency field like this, you're going to see some horrific things, you're going to experience some terrible things, and you should be seeking out help with that. And I think it's going to take time, but we can change, we can change the direction of the needle if we just keep reinforcing that message, and making it, more acceptable. So.
Thanks, Eddie. No, very important, especially, keeping that message. I want to bring in Chris and Kim. If I know we're running a little bit short on time, I'm seeing some of the questions from Florence, Amy, and others. Thank you so much for those that are here on the webinar. Keep adding the questions in the Q&A. We're going to have some time to answer some of these questions. So I'm going to kick it to Chris, and then to Kim, and then we'll get to our last panel, which is the future directions bit, and we'll open the Q&A after that. So hang tight, everybody. We're almost there. So Chris, go ahead and add in. You heard Tim and Andy talk about some of the issues with stigma and the workforce and the messaging that needs to go. What do you see?
I really appreciate what Andy just said. And just to maybe piggyback on that, I'll be real brief with two references for people to take a look at. There is a wonderful documentary called Triage that talks about the kind of vicarious trauma of a ER doctor working in war zones. Highly recommend that. And then there's an older one. I'm probably going to butcher the name. I apologize. But Romeo Dallaire, some of you may remember this, back in the mid-2000s, he was a UN, I forget if he was a general, but he was up there, and he was talking about, he wrote a book, and I think there's a documentary also perhaps made about it, but he wrote a book called Shaking Hands with the Devil, and it was his experience as this, gung-ho military guy dealing with the atrocities that he saw in post-genocidal Rwanda, and how that created an emotional mental health issue for him, and he talked about that. So I would highly recommend those. Take a look at them if you're in a leadership position, and see if they might be something that might help spur discussion, and certainly it helps normalize the issue of dealing with that of mental health issues in a traumatic situation.
Thanks for that, Chris. Go ahead, Kim.
I'll just, kind of add to this really quick, and coming off of that, I think what we're seeing is this is also consistent with national trends. So we've got to look at it in global trends in terms of people leaving, like we said, quitting, things like that. But this is also higher. The trend is around 47 to 51%, a little higher in the United States than other countries. But we're talking a much bigger number here. And when we're talking 69% changing to an entirely different field, and given the experience we need, we have to look at this a little bit closer. I'd also like to just acknowledge the generational intelligence piece of this. The world is shifting. The average position is around 2 to 3 years for this 18 to 35-year-old group. But what are we looking at if they're just dipping their toe in for less than a year? Some of them are coming out and going through higher education programs with a master's, getting into the real world and saying, this is not what I imagined. So we've got to change that. And I think too, for those of us that have been in this for a while, there is a shift in technology. And one of those great GQ tips that I got from someone was, they don't need to access authority figures for information before anymore. We used to have to go to our supervisors, to our bosses, to get access to that additional information. Now they can go get it on their own. So we have to shift our role to the coaches and the mentors and things like that as bosses and supervisors. So when they come to us and we say it's okay to ask us to be vulnerable, we have to understand how to respond to that, and how to coach and mentor and meet that, and meet them where they are, if we're telling them to go ahead and do that. So back to you, Sonny.
No, thank you so much. And in the chat, Latoya agrees with you, and also agrees with Tim and Andre earlier of saying, a shift in culture can match generational shifts that we're seeing. Maybe help to recruit and retain younger persons who are already embracing the type of cultural changes that we're all discussing here. So thank you for that, Latoya, and thank you for engaging with us here on the webinar. Let me kick it to Richard. Thank you for the panel. We have one more round of future, but Richard can kind of give us a good summary of the data, and then we'll get right into the Q&A right after our big takeaways from our speakers.
All right, Sunny, thank you very much. Interesting enough, there's a tremendous amount of research that shows that psychosocial pain metastasized, but shows up as physical pain. And so when you take a look at the issues with regards to drug abuse and so forth across the population, untreated or undertreated mental health can lead to other issues with regards to substance use disorders and so forth. So we just happen to know it because we published the Journal of Opioid Management. We've seen a lot of research in that field. So moving forward, let's see, future directions and funding. We still have a lot of work to be done here. This is a really interesting chart. Basically, this shows all the different sections in our survey. I took this chart and basically the stuff that's filled in bright yellow, that's really the data that we're representing here today. We have lots of other information in the database in the survey that we collected. We talked about job satisfaction, sufficient education, mental health available. We talked about that. Do we bring stressors home? Technology, team building, organizational structure, emergency management traits, and so forth. So there's a lot of work to be done here to basically analyze the data and bring and take a more comprehensive look at what's going on in the emergency management field and how these other aspects play into their stressors and so forth. So let's take a look at future directions and funding. There is a lot of work to be done. We do want to do a longitudinal data collection. We really need to do the next round of the survey. We're now about two years past when we collected the first data. We need to do it again and collect longitudinal data. We need to survey PTSD for those coming into the field from other professions. And is this a unique cohort? We want to add a qualitative component to the survey. We think that this is really important. We want to create and locate tools to address secondary traumatic stress in the current emergency management population. I know that Dr. Bernard talked a little bit about that, and we'll have some questions on this going forward. We want to create and execute a media campaign to drive emergency managers to seek help and reduce stigma across the workforce. I think this is really critical. We saw it in the poll. There's still tremendous stigma associated with seeking mental health services for professionals in this field. We want to create and locate tools to measure organizational culture and help retool those organizations that have issues. We want to create and execute a media campaign to educate organizations to these organizational culture issues and institute that change. And we want to continue analysis of the existing comprehensive data set. We also want to take and study emergency managers outside of the United States, as this was a US-centric survey. We know that emergency managers outside of the United States don't have the deep access to technology and funding, and they typically utilize more human capital. And so we want to do purposeful recruitment and analysis of differences in gender identity, expression, race, ethnicity, and possible religious expression in the field. Since this was a convenient sample, we surveyed and request people to take the survey, but we did not work to recruit more from these different specialties. And really, this is just the beginning. So again, we are seeking funding to further explore the data set and to continue the survey going forward. So I'm going to throw it back to Sunny to bring us to our last panel discussion. Sunny?
No problem. And then we'll get to the Q&A. I think this panel discussion is kind of what everyone's been waiting for, talking about the now and the future directions that can move forward with. We'll start with Andy. You've been dropping a lot of great insights and sharing a lot of maybe services and resources that are being available to those working, at the federal level. what are some directions that you could share with us that you're hoping that in a year time would be from the changes that you're making?
So in one sense, what we've been trying to do for the federal workforce is sort of implement a cradle to grave approach, where as soon as you're onboarding into the agency, you're already being familiarized with our mental health support. And, we maintain mental health web pages. We've got, and what we're basically trying to do is we're trying to measure the impact of those things and if we're positively influencing things. Recently, we've, for example, implemented a post-deployment survey. So as you're out processing, you're being offered the opportunity to seek mental health issues. You're being warned of things that you might encounter in the future, and we're trying to follow up with things. And everything is sort of categorized towards ensuring that the employees understand that the agency is there to support them throughout their career. And and ultimately that's what we're looking to do. And I think the next step is probably to be talking to our state, local, tribal, and territorial partners to see how we can translate some of these things, into things that they can potentially adopt. As an example, when we have mental health professionals who are circulating around the Joint Field Office or one of our disaster recovery sites, to let people know that they're there, and to give them an opportunity to break away and privately and just talk for a little bit. Those are all things that create a positive impression with the workforce, that their concerns and their issues matter. And I think ultimately that's what we have to convince the emergency management workforce, is to make them recognize that they are supported ideally, and to give them opportunities to get the support that they need if they have special concerns. And I think yes, mental health resources are at a premium in this country, but this is one of those places where because of the work that emergency managers do, we can't just accept the fact, well, they're just going to have to get by. If people are leaving this career field, and this is what's keeping this country safe, and these are the people that we need in there to keep the country safe and protect the public, then there has to be a commitment to hire, to train, to provide, either on a volunteer basis, on a paid basis, federal assistance, whatever it takes to really change the trajectory of this, and and enable emergency managers to work disasters while still maintaining their mental health.
Thank you for that, and stick around there's some in the Q&A questions for you as well. Feel free to look through, and I'll come back to you with the Q&A part. But we'll move to Chris. Chris, maybe some final words, thoughts around future directions, things that are mentioned so far, and then we'll go to Kim, and then we'll open up the Q&A. Chris, you're on mute. Thanks.
Sorry. Thank you, Sonny. Thanks for this. I'll be brief and just kind of have a bit of a highlight reel. I think, something to take a look at and double down on would be more peer and professional support opportunities, and to figure out ways that those might be able to fit into people's departments, to normalize and role model self-care, and with regard to that, to decreasing the stigma of reaching out for whatever kind of help that might be. That, I think, then leads to a better opportunity for more of a culture of support. I think one of the things Kim said, it really resonated with me, is just the need to have more specialty kind of training with this population. I think that's really a really good point. There's a lot of stuff that the American Psychological Association does through its divisions with specialties. And I had years and years ago, we've done disaster response training and things like that, but it was more so with the victims of it rather than the providers of care during those things. And I think that would be a fascinating area to get involved with in academia, and developing a subspecialty in that could go a long way. I think also then for people in their own curriculum for emergency management to see if there could be an addition of some, I don't know if it'd be a 1 credit hour course or something in that curriculum to tweak it around self-care, of how to self-identify, identifying others, and what to do. And then what Dr. Bernard said to measure impact. I'm a guy that grew up looking at outcome studies, and I think it's all, what gets measured gets monitored, but and matters. But I think also taking a look at what we try out and experiment, see what works, scale it, let go of what doesn't work.
Thanks. Go ahead, Kim.
Okay, so just, I'm really interested, and there was even a comment about it, and I think it embraces this cultural competence piece. In this field, if we are going to recruit and retain people better, we have to have a more representative voice. I mean, even just look at the panel and who's here and who we have on it. People need to see their own community when they're responding, but that also means that we have to do a better job of doing outreach and bringing people up in this field. So they might be disadvantaged or from a background that's there. So how do we support them? And if they're coming in with more trauma, we're tending to draw from different fields like the military and first response organizations traditionally. And those people are kind of bubbling up in HR systems as they're hitting the wickets, as we use different models of intelligence to kind of make up for some of the HR systems that are there. So how do we do that? How do we increase the diversity that's there? We do know that organizations that have the more diverse pictures at the top tend to be healthier organizationally. So how do we do that? How do we bring it up? And I think that is something I'm really interested in, and especially on a future study piece, really looking and targeting how can we do that better from a research perspective as well as a practical perspective.
Thank you for that. And I just wanted to, on behalf of the authors of the study and everyone here, I just want to thank the audience for being part of this. And also thank you to our esteemed panelists and Richard and the Journal of Emergency Management for really spearheading such an important study that needed to be done and will continue to grow on top of that. We have already 17 Q&As here. I'm going to bring in Richard. Is there any last words you want to say before we get to the Q&A?
Let's get started with the Q&A. I know we're running a little bit late, and we appreciate everybody hanging on here. This video is recorded, and it will be available after the event once it's sliced down by Zoom and so forth. So let's go right to the Q&A. Go ahead, Sunny. We'll ping pong back and forth. Well, let me start. We have Dr. Schoenfeld. She had a question for Dr. Bernard. Is FEMA offering the same resources to FEMA employees and volunteers, specifically the pre-deployment self-survey, and are team leaders then having conversations with those who are deploying to build a pre-plan?
Right now, it's been focused strictly on our employees as we were implementing this, but as we gain more experience with it, the goal will be to try and get it to everybody else that we work with in this space, as something that they can do. That would include the volunteers. It would include our federal partners who may be mission assigned to us, because truthfully, we want everybody who's going to be participating in the disaster, from a response aspect, to be able to ascertain, to make sure that they're ready for it. So not yet, but I expect that will happen in the not too distant future.
Okay. Thank you, Dr. Bernard.
Thanks. There's a question. Yeah, there's a question here that I just flagged that I think maybe I'll start with Chris. It was in regards to Dr. Robert Freeman said, I'm curious what professional recommendations you all have for individuals who have emergency management and behavioral health experience looking to support our colleagues in the field. I'm finding that the full-time employees opportunities are few and far between. Maybe Chris can start with you, and then the rest of the panel can kind of chime in of the opportunities that we could support.
Sure. I just, from a personal experience, I just on Monday had a meeting with our county level emergency response coordinator and kind of went into with her with a couple of different kinds of agenda. But one of the things we sort of settled in talking about that hopefully might be helpful to this question is to let them know what your services are, what you're available and doing, what your background is in terms of being able to provide those kinds of services, experiences and trainings in particular, and that maybe if there's some way that you could sort of give some examples, at least by virtue of sensitivity, that if let's say you're talking with a director for their staff, a way to maybe give a workshop. That's a nice toe in the water, foot in the door way to have someone start to understand who you are as a person. A lot of times people, the stigma that goes along with seeking mental health services is that they may not have an innate trust of who that provider is. But if in a very non-threatening kind of way, if a person can come in and give a workshop on stress management, coping skills, dealing with the stresses of a teenager while you're at work, et cetera, et cetera. A variety of those kinds of things can be very nice gateway drugs to being able to develop a relationship and then be able to provide other kinds of services, starting off with workshops and then getting down to consultations or maybe even providing therapy.
Yeah, thanks for that. Andy, anything to add? Do you see some of that? I guess that would be towards the volunteering, looking at volunteering opportunities, or
Oh, certainly
any suggestion?
certainly to volunteering opportunities, but as we're looking at mental health across the DHS enterprise, I mean, there are increasing opportunities for mental health professionals to function in an employed fashion. I could certainly see a model that, would have it done at the state level and, perhaps eventually down at, like a county EOC level, where when an EOC activates, that maybe part of the automatic response of that is that a mental health professional comes in and begins to support the staff that are working around the clock to try and keep their community response, in order. Every time the National Response and Coordination Center up in Washington, D.C. activates, we automatically bring in mental health professionals that are circulating around. And, you've got 800 people who are trying to coordinate the national response, and it can be stressful. And so, we make sure that, we have mental health professionals there right from the beginning. Similarly, into the incident management structure, we are in the process, at the direction of the FEMA administrator to bring a mental health advisor role into that, and providing advice to the federal coordinating officer and the chief of staff and the rest of field leadership on ensuring things that are, to better support the workforce, during that disaster response.
Thanks for sharing that. And I'm going to give space for Kim, because I know we're running short on time. Kim, and then maybe back to Richard if we have time. One more last question from Richard, but if not, we'll kick it to Kim.
Yeah, I think it just, one of those factors that falls into this too is kind of and maybe this is where the national to the local level and down kind of has an impact. But we saw that statistic that 51% is too political on the job. So and that is a big contributor, that organizational stress and the feeling, especially on the funding side. If you have multiple disparate funding sources, even at the federal level, that are dependent upon continuing resolutions and things like that, it's translating down at the local level to not being able to fund the full-time positions. So you're ending up in a reactionary model that then contributes to that additional stress. So I think there's a multitude of things that we uncovered in this study that need to be addressed in a deeper level. And also there's some deep dives and some cross correlation that needs to be really examined to see what and how and where we tend to look at this at both the individual or at all three levels, right? The individual, the team, and the organization, and then at this kind of high level field-based component to this. And so I think where I'm really interested now, and especially the questions have been really interesting and insightful, is it can kind of help drive some of those additional questions that need to be answered as well. So thank you to everyone who's been on this panel with all of us, and also to the audience for asking the great questions and pointing things out. Back to you, Sunny.
Go ahead, Richard. Take us home. We got 3 minutes left. Let's try to see if we can make this.
Fair enough. Well, before I get, there's one more question here, but let me read it off. It says, "This is an amazing webinar sharing the results of your much needed research. Thank you." Well, thank you for attending. The focus was on negative impacts on mental health, which are critical to understand. In contrast, is there a meta-analysis study or report that you can recommend comparing different mental health support approaches that have evidence of being effective? You just throw that out to whoever would like to take a shot at that. Chris?
Off the top of my head, I mean, the whole aspect of evidence-based practice is critical, but I think it's such a nascent kind of area. I doubt that there's been a lot of, I'll say, first of all, I'm not aware of them, but I sort of doubt if there is a great database to be able to look at outcomes to then be able to presume treatment guidelines or evidence-based practice approaches. But I would highly recommend that would be an area of focus. But I'm just too, I'm not aware of them. That doesn't mean they don't exist, but I would be pleasantly surprised to see it.
Okay. Thank you, sir. Well, we have, what we'll do is we will forward all the questions that are in the Q&A section to our panelists and let them have the opportunity to respond in email. We'll figure out how to get that all done. Once again, I want to thank you all for your attention today. I know this was a long webinar. We're coming up on effectively an hour and a half on what was supposed to be originally a 60-minute webinar. I do encourage you to please reach out to our contacts. Their contact details are here. They'll be happy to answer any questions. This is not an end-all webinar. This is the beginning of a journey to figure out how we can better support emergency managers and their mental health and the profession going forward. So once again, I want to thank you for joining us. If you want to talk more, I'll be at the IEM conference next week in booth 638. Okay, we ask you to please take the post-webinar survey. We will send you out a link, or you can take a picture of it with your phone. And once again, I want to thank you all for joining us today. This is a wonderful webinar. I want to thank our panelists. You're simply outstanding. Dr. Bernard, Dr. Stout, Dr. Erickson, Kim, Sonny, Dr. Lucas, thank you all for joining us. Thank you for your dedication to this really, really important topic. And I thank you all for joining us today.